The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. I'm going to welcome you to today's webinar. My name is Joe. My name is Joe Schannebarger. I'm with the Training and Implementation Department here at PrognoCIS. What we're doing today is the third video in our series on the QPP, specifically MIPS, for the data capturing requirements within PrognoCIS in order to demonstrate your compliance with the quality payment program. So again, we have different sessions going on with regards to the other options, such as meaningful use stage 2 or stage 3. But what we're going to look at today is the data capturing requirements under the quality payment program, specifically MIPS, which is the merit-based incentive payment system. This is just a summary slide from our previous session where we actually go into the explanation of what the MIPS program is. And basically for the year 2017, there are 3 categories of data that you have to report on. And that's what we're going to look at as far as the requirements in PrognoCIS. These categories are quality, which has a requirement of 6 measures, and they can be selected either from claim-based or EHR-based categories. The second classification is advancing care information. Now within this classification itself, there are 3 categories: base, performance, and bonus. And then we've also got the improvement activity category. Now, for 2017, CMS is allowing the provider to choose their level of participation. This choice is what determines the number of days for which your data has to be captured. For instance, the test participation does not have a predefined number of days, nor a required number of categories that you must report on. As long as you report something, meaning at least 1 category, at least 1 day, then you will not be penalized with a negative payment adjustment in 2019. Of course, you also would not qualify for any positive payment adjustment either. The other 2 choices would be partial participation or full participation, and those 2 choices, you do have a set number of categories under each of those classifications, but it's the duration of data that you report that makes the difference. Partial participation requiring at least 90 days minimum, full participation requiring the full year. Now, both of those would allow some sort of a positive payment adjustment come 2019. So whichever participation level you choose, what we're about to cover will be applicable to the measures that you're going to be reporting on. So first of all, we're going to look at the quality category. Again, summarizing the requirements for the quality category, when it comes to capturing the data, you do have to choose at least 6 specialty relevant measures. At least one of those 6 must be defined by CMS as an outcome measure type. And if there is no outcome measure type specific to your specialty, then you need to choose one that is designated as a high priority. All of your measures must be defined under a single method of data submission, meaning either claim-based or EHR-based. And you can choose more than 6 measures if you so desire to qualify for bonus points. With regards to the 2 categories, claim-based measures are applicable to Medicare patients only. When you choose the claim-based method of data submission for your quality category, CMS will automatically pull the data from the claims you submit. As long as they include the appropriate quality data code along with the required HCPC or CPT codes and diagnoses, then you would be compliant for the applicable measures. With this methodology, there is no separate attestation required. So throughout the year, throughout the 90 days, whatever period you choose, as you're submitting your claims, the data would just be reported on by CMS in the background. Now, if you choose the EHR-based measures, this is going to be applicable to all patients, not just Medicare only. This will require an attestation, which doesn't start, of course, until January, or EHR submission directly from PrognoCIS. We'll, of course, be having new webinars come January with regards to those particular choices. The data requirements are different by measure. For instance, under the EHR-based measures, there may be required encounter code sets. This could require CPT or ICD, SNOMED, LOINC codes, RX norm codes, and so on. Plus, there may be conditions, exclusions, and exceptions. So there are differences with the way the data is captured and what your requirements are. So choosing that methodology, whether it's going to be based on the claims or the EHR base, is certainly one of the most important pieces in determining your quality data capture. Now, we have a separate webinar and training video on doing your setup in PrognoCIS, so we're not spending time on that today. This is just a summarical reminder that under your meaningful use QPP settings, you do have to define which measures per each provider you're going to go for. So as you see here next to the number 2 bubble, you do choose either from the claim-based or the EHR-based. Down below would be the applicable measures for each of those categories, and you select the checkboxes for the ones you want to be tracked within PrognoCIS. Now, first we're going to look at your claim-based quality measures, in case that is the option you've chosen, and how to validate those at the encounter level. On your encounter screen, you do have a menu option called Quality Measures. You'll see that there on the lower left. This menu option will always display, but it is only going to be enabled for Medicare patients. So based on how patient registration enters your insurance, if it is a Medicare insurance type, then this measure, Quality Measures option, will be available to you on the encounter level. All claim-based quality measures that you have chosen in that slide up above for the attending provider of the encounter will display on this screen with a pass-fail status there in the far right column. And that is what we're going to look at now as far as how you're going to validate each of these measures for the encounter. At the top of this screen, you will notice that there is an info button. Now, within this info button, you're able to view the definition and the requirements for the measure that you have selected down below. So if I go back up here to the main screen, you'll see that I have 6 measures listed on the screen because Dr. Sheldon Cooper has defined these 6 measures under the Quality Claim-Based tab. I've got the bottom one highlighted in blue. These buttons that we're looking at are applicable to the one that you currently have selected in blue. So in this example, I've chosen the diabetes hemoglobin A1C poor control. When I click the info button, it is opening the denominator and numerator criteria for that measure only. So I see the age, the gender, the specific ICDs and or CPTs that are valid within the measure. And then for the numerator, it also will tell you the different scenarios as well as the quality data codes that need to be included on your claim. So this is just informational, so that as you're learning the measures and feeling what the requirements are, you'll understand then what needs to be encapsulated within your documentation for that encounter. Now, the next set of buttons there at the top are the assigning of ICD and CPT HCPC codes. These will be applicable when you want to view the codes. As you see here at the bottom, it'll give you the ICD-10 code choices as well as CPT HCPCs. All of these are the ones defined here in the denominator criteria as being valid for the measure. The nice thing about this, however, is when the status says fail, as you see in my screen snippet, if you choose one or more of these codes within this window, they will transfer over to your assessment. So when you update this quality measure screen, it simultaneously will be updating your encounter level assessment. So the failing is going to be with regards to the ICD-CPT codes. So that is the denominator status. Once you have chosen a valid ICD and or CPT HCPC, you will notice now my fail has changed to pass, and my highlighted message in parentheses now says missing quality data code. Formerly, it was called a G code, so that label in my screen capture is saying missing G code, but that's referring here to the QDC, or the quality data code. And when you click that zoom icon under the QDC column, that is going to then populate all of these different quality data code scenarios for the numerator. And then here, of course, is where you want to make the clinical judgment on the different scenarios, which one is applicable to your patient. When you choose that code then and update it, it is also going to transfer over to your assessment under the CPT HCPC tab, and therefore transfer onto your claim. And so if we now look at the assessment tab, once you've gone through that process, you will see here in your source column, the code says QDC, so that you know that you did go into that validation tool and you have chosen an appropriate code. Now, if you use PrognoCIS Practice Management, this will automatically be added to your claim when the claim is created. If you do not use our practice management, then when you run your quality measure report, these codes would be applicable on that report so that your outside billing service would know to include it on your claims. Now, that is your claim base. So you have a screen there called Quality Measures on the encounter level with the pass-fail status and the different icon links to help you step through each measure. Now, if you've chosen the EHR-based instead of claim-based, that is handled a little differently. This is now entirely at the assessment level because it is not dealing with charge codes or claim matter. It's dealing more with the clinical aspect of coding. So when you go to your table of content assessment, you will have an ECQM button up at the top. And similarly to your quality measure option we just spoke of for the claim-based, with regards to your EHR-based, this button will display all of the ones that you have assigned to the attending provider of the encounter. So back in our QPP master, when you have chosen your 6 measures under the tab, whatever ones you've chosen are what will be displayed here. And then you've got these different columns. The number 1 and number 2 bubbles here are encounter specific. The number 3 bubble is attending provider specific for the entire reporting period of MIPS. So it's kind of 2 birds with 1 stone here. When you go in here to your EHR-based dashboard, you're able to see how this specific encounter is stacking up, passing or failing, excluded, not applicable. But for each measure, you also can see your personal statistics as a provider with that measure overall. If there is an exclusion, then it would actually say excluded, or it'll say not applicable. The denominator and the numerator columns, similar to what we just saw up above on claim-based, is going to have either a pass or fail status. In the case of pass, there's nothing else to do because that means your codes support the measure criteria. You'll notice the word fail, however, is underlined. That is a hyperlink that is going to open up more detail for you. Now, this is going to be a little more complex as far as validating than what we saw up above. So to dissect this dashboard so that you know how to use it, first of all, for each measure, in the far left column, you're going to have a little notes icon next to the quality ID. If you click that icon, that is going to open up the entire definition of the measure. So on our claim-based, we had a little info button. It opened up the table of applicable codes. Well, here, since we're dealing with clinical scenarios, it's going to be more complex. It actually opens up an HTML document that has different formulas and calculations in it. So don't be alarmed by the verbiage. You're not back in high school algebra. However, in order to understand how to document your encounter clinically within the context of these measures, you do have to understand how the formulas are written. You'll notice there next to my number 2, we have A plus, B or C plus D or E or F, etc. And that's what we're going to look at now in the next few minutes, how to read these formulas so that you know how to document your encounter. And just as in math class, you have plus and you have slashes. These are going to indicate whether you're combining the conditions or it's an either or scenario. And this is how you will determine whether or not this encounter is passing or failing, based on if these different conditions specified within the formula applies to your patient or not. So for instance, in the denominator, you have different data conditions that must exist in order for that encounter to pass or be included in the measure. So taking this simple one, the denominator, that we have it spelled out, and I've kind of tried to break it into a couple of different color coding to explain it as we go down the page. The first criteria is classified within the document as formula A. Then you've got the plus sign, meaning not only does A have to exist and qualify, but then also something that comes next. But now after this first plus sign, if you see the part I have in green, you've got or. So now we've got different conditions, and it's an either or scenario. So in addition to your A scenario, you also must have either B or a combination of C plus D, or either E or F. And that whole part is inside brackets. So just as again in solving an algebraic expression, you have to take what's in those parentheses or brackets, get the sum, the value, and then that's going to get added into the first part. But then here we've also got the ending, which is plus G. So basically for this particular measure, in order to be included in the denominator, you have to satisfy with this particular encounter must have formula A as well as formula G, and then in the middle, it also has to have one of these additional three scenarios, but not all three of them. So we see here formula A is patients with age greater than or equal to 18. So basically this is going to be applicable to all of your adult patients. So if your patient is less than 18, this measure doesn't apply. So you don't need to worry about it. If you go all the way down to the bottom, the G part, the encounter during the measurement period must have a relevant code in the assessment. Now, as we'll see here in a little bit later, we have within these EHR-based measures the term encounter code set. So this is not the PrognoCIS encounter type code, but this is going to be a CPT code, an E&M code, a SNOMED code, something that CMS has said identifies that encounter as to what type of encounter it is. Is it an annual wellness visit? Is it just a plain office visit, a face-to-face, etc.? So off the bat, in order for this measure to apply, you have to have both the adult criteria specified in A, meaning the age. That's coming from your patient demographic screen, of course. So in order to calculate this data, your dashboard is looking at patient register, looking at the patient's age. Then it's also looking at the assessment screen, and do you have a code to identify it as an office visit, a face-to-face, a preventive care, etc. Both of those conditions then must be accompanied by one of these others. So now we're going to look at, is the patient diagnosed with acute myocardial infarction in the last 12 months? Or does the patient show has the patient been recovered from an ischemic vascular disease and also diagnosed with ischemic vascular disease before or during the measurement period? And it goes on to say the relevant code should be present in past medical history with a recovered status and or with an Icd SNOMED code. And then the third scenario would be patient discharged alive with a procedure performed for percutaneous coronary intervention, as identified again by the CPT code or SNOMED code, that you did that procedure. Or did you perform a coronary artery bypass? So basically, this is going to be applicable to an adult patient in one of those encounter types, and then it's going to look at, so it's looking at your patient demographics to get the age. It's looking at the assessment screen then, CPT HCPC, to make sure you've got an appropriate code identifying the type of encounter. Then it's going to look at past medical history to see, do you have an ICD code or a SNOMED code identifying acute myocardial infarction or ischemic vascular disease? And if it's the ischemic vascular disease, have you identified it as being recovered? Or is it newly diagnosed? Or did you do a coronary bypass or a percutaneous coronary intervention? So there's a lot there. And I know it just spilled it out of my mouth here. It takes a little bit to digest. But basically what this is showing you is that within the content of each of these measures, there's no just one place that you go to in PrognoCIS and click a checkbox and pass. Because every measure has all these different criteria. Some are age, some are gender, some are both. Then it's going to look at a different range of diagnoses, different procedure codes. Did you order this medication? Did you do this lab? And the combination of all of that is what determines pass or fail. So the key is just understanding the measures you've chosen to go for, knowing, and that is why it's important to choose those ones that are specific to your specialty, because quite honestly, even though this seems really intrusive, if you're doing your job as a medical care provider and you've chosen measures specific to how you care for your patients, is going to be automatic as long as you're documenting your record thoroughly. Now, in this particular case, we're also demonstrating where there's exclusions or exceptions, because what we just said is the initial query. Does this encounter even qualify on those different scenarios? Now, if they do, we can look and see, are there exclusions? Because maybe it applies to 8 out of 10 of your patients, but the other 2 may qualify for an exclusion or an exception. Now, an encounter is not going to be counted at all if there is an exclusion satisfied. So it may have counted up here because those conditions were met. So in your measure count, it would say 1 in the denominator. However, if now the exclusion criteria is applicable, it's going to subtract it out of your denominator. So it would not be included at all. So an example here of an exclusion would be A or B or not E plus F. So again, now we're getting into some more complex scenarios, and they're very specific to each individual measure. But basically here it's saying that even though you have an adult patient with myocardial infarction that is in a face-to-face encounter, you don't need to count them today if, condition A, the patient is receiving palliative care based on the encounter code set. And again, that encounter code set, which we'll see in a moment how you choose it, can be a SNOMED code or an ICD code. If they're not receiving palliative care, then the B condition, no physical examination of height and or weight was done because the patient refused. If neither of those is applicable, then the patient can be excluded if they were pregnant and the pregnancy ended prior to the start of the measurement period. And again, that has to be represented by the SNOMED, the ICD, or the ICD 9 or 10 within past medical history. So here again is going to be looking at past medical history. Is there an ICD code? Is there a SNOMED code documented for these different scenarios? In addition to assessment CPT code to identify that encounter code set. Similarly then for the exception, basically an encounter is included by default when the conditions are satisfied. However, due to the condition specified as an exception, it will now be deducted from both the denominator and the numerator. So there's really a fine line here between what is excluded and what is accepted. Honestly, to you, the bottom line is the same net result. If it's an exclusion or an exception, you don't need to worry about having that little pass status because it's not going to be included within your overall reporting. The ones you need to worry about is when it says fail. You want to make sure those say pass. So again, these are giving you different conditions. For some reason, when it gives you an exclusion, it uses the word or. When it gives you an exception, it has the slash mark. That slash mark means or. So again, it's going to be condition T or U or V or W or X. Now here, if you notice, this is now looking at orders. So up above, it was looking at past medical history for specific diagnosis conditions, pregnant or not, myocardial infarction or not. It was looking at your assessment procedure codes that were done. Now it's going to look, were orders done? Did you do an interventional order? Did you do a medication order? So now it would be looking at current medications, prescriptions, CPOE, procedure orders, etc. And it's going to, again, since it's an or, it's going to look, did you do this, or did you do this, or did you do this? And if so, it would determine an exclusion or not. So if you don't have any of those orders documented, if you don't have any of those prescriptions documented or medications, then that exception does not apply. Therefore, the encounter would be included in your count. And then similarly for the numerator, which is again now determines are you compliant or not, you're going to have formulas to look at, which could be a combination of and scenarios or scenarios. So in this example, we're showing you a combination where in order to pass compliance, you must have all 4 conditions satisfied. And incidentally, these little snapshots I'm giving you are not the same exact measure in every slide. I just found snippets of different measures so that I could demonstrate all of the functionality. So in this particular scenario, if you look at the numerator, it says patient with total cholesterol, patient with HDL-C, LDL-C, and triglycerides. 4 specific laboratory tests must be documented, and with the result, there must be an LOINC code to indicate that result. If you've only got 1 of those, or 2, or 3, or none, you would not pass. It would say fail, because it's requiring all 4, since it has the plus sign, I plus J plus K plus L. So that was reading the document. From top to bottom, when you click that little icon, you're going to have all of that for each measure. Now to validate it within the same ECQM dashboard. Again, you see here my number 1 has excluded. So denominator and numerator are not applicable, so you don't need to worry about it. It's not part of your reporting period because of one of the above scenarios is applicable based on what you documented. You ordered an intervention. You prescribed a medication. Therefore, that encounter doesn't qualify anymore. Number 2 shows a status of pass. Again, all of your documentation satisfied. You've got the appropriate diagnoses and SNOMED codes, etc. Status fail, however, you need to work because exclusion says not applicable. Your denominator fails, your numerator fails, so this would be a negative on your reporting period. And remember, if you attended one of the earlier sessions or just from your own CMS research, everything under MIPS is performance-based. So when the CMS is having you attest your data come January and you submit this as part of your reporting and you failed, then that obviously is going to give you less of a score in your performance category. So this is when you would click on the hyperlink and view what the criteria that is failing. So now taking those examples up above, we're going to dissect it at the point of validating. So for instance now, in my denominator, if you notice the point B, the column lists only the conditions that are failing. So you'll notice under my title formula, it says D, E, F, G. However, if you follow your eyes across the page from my B bubble, the title gives you the full requirement. A and B, or C and D, or E and F, the brackets again, and G. So in this scenario, the fact that my A and my G are gone, only the conditions are what's failing right now. So the A and the G pieces are satisfied. And you know that because they're worded in the title. However, in the formula column, they're missing. That means they're satisfied. So now you look at the ones that are available to you in that formula column. D, E, F, G. You look in the title of the formula, and this is all within the brackets. So now you're going to decide, is it B or, now in this example, I guess I apologize, my B and C are also gone. So you would also have to know what B and C represented, and then decide if any of these are applicable. Now, reading this is exactly what we saw up above. It's just a matter of which one applies to the patient in front of you. So if you wanted to go, for instance, for the C and the D, patient is diagnosed with ischemic vascular disease before or during the measurement period. The relevant code should be present in assessment or past medical history with active status. What that is saying is, if you put under your assessment an ICD SNOMED code or under past medical history, it shows an active diagnosis based again on ICD or SNOMED for ischemic vascular disease, that would satisfy Formula D. So in order to make that D go away from this screen, you would go to your assessment or past medical and enter that ICD code. And then that measure's criteria would be satisfied. Now, if you notice in the far right, my C bubble, this icon is where you're going to get these encounter code sets. So within the description where it says view relevant codes, whether it's an ICD, a SNOMED, an LOINC, a HCPC, etc., all of those codes are called an encounter code set. And again, this is not a PrognoCIS encounter type code. This is a clinical code. And then the numerator is going to be the same thing. When you click fail, it's going to bring up there in the far left the formulas that are failing. And then in the far right, you'll have the icon to display the code sets, which will make it pass. So basically, these two slides are identical. It's just the content underneath the hyperlink is what's different, because one is for the denominator, one is for the numerator. In this case, since they both failed, when you open up the link, it gives you only the pieces that are failing in the formula column, but the title tells you the requirement. That way, again, if you think in terms of mathematics, even though we're dealing with clinical scenarios, you can kind of figure out what you need to make sure is done as far as crossing your T's and dotting your I's. And this is example then when you click that encounter code set icon. Now this particular screenshot, I've just photoshopped it to show you every possible value. You will not always have a CPT, a HCPC, an ICD, etc. It all depends on the measure. Because when you're looking here, for instance, in my numerator, all of these are based on LOINC code. So when you click that little icon under the C bubble, all you're going to get in this pop-up is LOINC codes. You won't see RX norm or SNOMED, because the encounter code set in this particular scenario is only looking for an LOINC code. But if you look at this definition, where it says click on the icon to view relevant ICD-9 or ICD-10 or SNOMED, if you look down a little farther, it's like condition E and F, it's to view relevant CPT or HCPC or SNOMED. In that scenario, when you click the icon, then you will see CPT, HCPC, ICD. So again, this is just a representative screenshot to give you an idea of what would be there. But it is all very specific to the measure that you're reviewing. And then based on what the code requirement is within this pop-up is where you're going to enter it on your chart. For instance, your CPT HCPCs goes under the assessment screen. Your ICDs can either be under face sheet past medical history or under your assessment ICD. Now, LOINC codes can come from anywhere because your social history, your vitals, your laboratory, they all can have an LOINC code. So depending on the measure, again, is where you're going to know whether that LOINC code is present. RX norm code is relevant to medication. So it may be looking at your face sheet current medication. It may be looking at your prescription, depending, again, on how the measure is written. And then SNOMED can be anywhere, because clinically, when it comes to documentation, even demographically, a SNOMED code exists for everything. So basically, what all of this is saying is in order to validate your measure, if it fails, click the hyperlink. It's going to open up specifically the pieces that are failing. And then you click the zoom icon there in the far right column. It gives you the choices of what you can enter in order to make that encounter pass. And then if you do that applicable diagnosis, the fail goes to pass. So now we're going to look at examples of those different encounter code sets. And again, I've not included all of them, but just to give you a visualization. Example 1 is when a CPT or a HCPC is required. This again now is where, if you notice in my formula column, I do not have A and G. I have B, C, D, E, F. Well, I'm sorry, G is there, but A is not, because A is satisfied. If I look at my formula, again, A is required along with one of the 3 OR scenarios that I've outlined in green, as well as G. So first of all, I want to make sure G passes, because I know I need A and G. Then I can worry about the OR scenarios. Well, if I look there at the bottom, my number 3, condition G, in order to satisfy, says it needs a CPT code that indicates the type of encounter. So if I click that magnifying glass icon on row G, it is going to give me this pop-up and tell me what possible CPT codes will make that measure pass. I go to my assessment CPT tab, as you see here with my number 4. I enter that code. That gives me my G status. So, and this is an easy one. That is common. A lot of them, this is how it would be satisfied, is simply by putting a CPT code. Now, taking this same measure now, the next step, now we've conditions A and G are satisfied. So you'll notice now in my pop-up, when I click the fail hyperlink, my formula column does not have G anymore like it did here. Now I'm down to just the B, C, D, E, F, because I have satisfied A and G. So now I look at these different scenarios, B or C and D, or E or F. Whichever one of those 3 possible scenarios is applicable. For my example, I'm choosing the easy one, which is B. Condition B says the patient is diagnosed with acute myocardial infarction in the 12 months prior to the measurement period. Click on the icon to view the relevant ICD code. Well, when you click that icon, and find that diagnosis 41090 is valid, you'll see here at the bottom, I've added it to my past medical history under the face sheet. Now, in order for this to pass, since the criteria in the definition says in the 12 months prior to the measurement period, the since when date needs to be within the past 12 months, and the status cannot be recovered. So again, if you notice there on my number 4, not only have I added the ICD code for myocardial infarction that came up under my magnifying glass icon, I've also got to make sure my since when date, meaning since when has this patient been assessed with this diagnosis, and the status must show it as an existing condition. That then satisfies condition B by adding that ICD code. Now looking at a different measure for LOINC code. This is that measure we saw up above where you need to have the 4 laboratory tests. All of those laboratory tests, each one must have an LOINC code associated. So if you notice at the bottom here, this is my lab result. Now for those of you who have an HL7 interface with your lab vendor, this is going to be automatic, so you won't need to worry about it. The LOINC code is part of your HL7 interface when the result comes in. However, if you do not have an HL7 interface and you're manually entering your results, the LOINC code has to be entered into your configuration test master. So you would go under configuration, input elements tests, go to laboratory tests, and make sure the LOINC code is there so that when you manually enter the results, the system can pull that LOINC code in. And then the last example we're going to look at would be the RX norm code. Now this is when the description is calling for medications. So again, here at the top, you see C or D. So in this case, neither formula is satisfied yet because both C and D is applicable under my formula column. Each one of these requires a medication that has an RX norm code. So when you click that magnifying glass on the far right, it would open up your encounter code set with all available RX norm codes. Now, RX norm codes are attached to the drug name. So you're not going to do a search of an RX norm code, 1, 2, 3, 4, 5. You're going to search for the drug. So when you click that icon, it brings up all of the available high-risk medications that you can prescribe. And if you prescribe that drug, whether you're doing it under your encounter table of content prescription or under your face sheet current medication, the RX norm code is in the background. Now you will see it if you hover your mouse over. If you notice my number 3 bubble, it doesn't show on the medication screen itself, but if you hover the mouse over, the tooltip will tell you the RX norm code is there. And since your drug database comes to you from the first data, you don't need to worry about this either. As far as the code, it will be there automatically. What you need to worry about is documenting you did the medication. So either entering it as a current medication directly to the face sheet or prescribing it would satisfy that. So whether it's a CPT code, an RX norm code, a diagnosis code, you need to make sure that the appropriate documentation is done. Put your diagnoses in there, order your labs, enter the results, etc. All of that is what will be gathered in the background to say, yes, you're compliant. So all of that is your quality category. Whether it's claim-based for Medicare only, CMS pulls the data from your claims. You can validate them from the menu option called Quality Measures. Or if you do EHR-based, you've got the ECQM button on the assessment. Both of those options give you the fail hyperlink that opens up what will make it compliant. Now, the second category under MIPS is ACI, or Advancing Care Information. There are 3 categories of ACI measures. You have base measures, all of which are mandatory, and there's 5 of those for 2017. You have performance measures, which there's a possibility of up to 9, and we recommend that you do all 9. And then there are bonus measures, which are optional. Many measures do count in multiple categories, such as 3 of your base measures automatically also count as performance. 2 performance measures automatically contribute as bonus points. And then you can get an additional 10 ACI bonus points based on the next category we're going to look at, improvement activities. All of those points, by the way, again, is in our earlier webinar, which if you did not attend, there is a recorded version of it on the website, on our resource center. Now, all of your ACI measures will be submitted during attestation. So there is no claim-based option here. Come January, there will be an attestation. Whether you do it directly into the CMS attestation screen or you use PrognoCIS to transmit it for you, it will be reported after the end of the year. And all of these performance measures are going to be calculated against benchmarks, which CMS has defined. Those benchmarks are not currently loaded in PrognoCIS. They are different for each measure. But similarly to your quality measure designation, you are going to go into the QPP master and indicate the measures you want. Now, if you notice here next to my number 1, all of your base measures will be pre-selected for you. And you can see that because the check mark is kind of grayed out. It's a faded gray. You cannot deselect those because they're mandatory. The optional measures, however, if you notice like my number 2 would be a darker black check mark. Those are the ones that are available, suggested, because you can get additional points. So again, whichever ones are selected here, whether they're the pre-selected mandatory or the manually selected optional, whichever ones have the check mark for the doctor on the encounter, those are the measures that are going to be tracked. First of all, we're going to look at the base measures. Now, this ACI category is what used to be meaningful use. So if prior to 2017, you already submitted attestations under meaningful use, Some of these measures are already going to be familiar to you. Some of them have been modified, however, for 2017. But for instance, the first one, security risk analysis, there's no data to be captured in PrognoCIS. This is a yes-no attestation, simply that you have conducted a security risk analysis in your office, and you have the documentation to show an auditor for up to 6 years. If you go to our resource center, if you're not familiar with what these requirements are, there is a document that you can download that tells you what is required in order to pass an audit. Basically, it's all of your internal practices to secure PHI is secure. You know, user login, confidentiality, training, all that kind of stuff. So this is a requirement. You will attest yes, but there's nothing to be captured in EHR. Now, measure 2, which is also mandatory, is e-prescribing. So here, the denominator is going to look at all of the prescriptions that you've written, and then it's going to make sure those prescriptions were queried for drug formulary and then transmitted by ERX. Now, if you'll notice in the green box and the little asterisk from the definition, permissible prescriptions, if you are not participating with EPCS, which is the electronically prescribing of controlled substances that requires a separate identity proofing and security token, then make sure that under the master, you have taken that exclusion. If you do not take the exclusion for EPCS, those will automatically be included here. Now, again, here since we're talking about MIPS, and I mentioned this is kind of the equivalent of what used to be meaningful use for you, there are no thresholds. So unlike previous years in MU where you had to satisfy 50% or 80%, that is not the case under MIPS. So it's up to you if you're going to do 1, 2, 100, 1,000, all of them. Keep in mind again, though, that since MIPS is performance driven, the more you submit, the higher your performance score is going to be when CMS puts you into those benchmarks. So I do suggest that you create self-imposed thresholds. But that also goes back to what level of participation you've chosen. If all you're worried about is avoiding a negative payment adjustment come 2019, then all you have to do is submit something. In the context here of ACI, that something is all 5 of these base measures. However, notice here the definition is at least 1. So again, if all you're worrying about is not getting a negative reimbursement, as long as you do 1 e-prescription, you're okay. But if you're going to do the full participation or partial participation for 90 or 365 days, then I would suggest every prescription possible you would want to comply with. The way it works in PrognoCIS, when you set up for e-prescribing, the drug formulary is automatic. So as soon as you enter a drug on the prescription, it fetches the eligibility and tells you whether or not they're on formulary. So that's nothing you need to worry about as far as performing it. It would be compliant. Now, if you need to know what the formulary options are, as you see here next to the number 2, you can click the icon and that would pop up all of the formulary alternatives. Choosing an alternative is not compliance. Compliance is simply having the formulary functionality turned on. It is automatically turned on for you when you become an e-prescribing provider. The sending of the prescription electronically, however, does of course require that you choose an electronic ERX pharmacy and actually transmit it through the ERX icon, meaning you cannot print it to paper. And this again is where if you're doing the controlled substances, you would need to have gone through the identity proofing, electronically sign that drug so that at the bottom it says signed, and then send it through ERX. But if you've taken the exclusion, then the controlled substances are ignored, so it doesn't matter. The third base measure, again, which is mandatory since it's base, also qualifies as one of your performance measures. This is requiring that the patient portal be enabled and configured so that your patients are able to access their PHI on the portal. So to be compliant here, as long as you have issued a user ID and password to your patient so that they can log in to the portal, or new to 2017 is the API, then that health summary is automatically made available through PrognoCIS. So as long as you have given them that access within 48 hours, you're compliant. The access is given under patient register. So you have the login info icon. This is to the patient portal. You can either auto-generate if they have an email, or you can manually define a password and tell the patient what it is. Either way is deemed giving them access. Now, new to 2017 is the API. The API is a separate URL than your portal. So if you're going to give them this option, you would need to have that URL available to the patient, meaning they would need to know how to access it, and then they can sign up for their own password. So unlike the portal, you issue the password from within PrognoCIS. The API is independent, where the patient can choose to give themselves the access or not. Either of those choices will give you compliance on this measure. As far as the health summary being available, that again is going to be automatically there based on what you've been documenting. So on the Encounter Close screen, you will now notice, if you haven't already got the upgrade, of which you should because it's been going on now for the last couple of months, there's new checkboxes called Share Health Summary, one on Portal, one on API. Those checkboxes are automatically selected, meaning as you are documenting, that health summary is viewable by your patient. So as long as they have the access to log in, then again, you are compliant with this particular measure. The next base measure, which also doubles as a performance, is to send a summary of care when you are transitioning a patient to another provider. So these would be your referrals. This is calculated under letters out by indicating it is a transition of care, referral, and then attaching the CCD document, because that is deemed the patient's secured PHI. So under your letters out, when you're generating this referral letter, make sure you choose that TOC checkbox, and then make sure that you've attached your CCD document. So when you go into that attach button from letters out, you automatically have this document generated called New Continuity of Care, or CCD, categorized as Summary of Care. You attach that, produce the letter out, and send it electronically. You are deemed compliant. Now, this does require secure email. So all of you that are participating need to be set up with that secured end-to-end messaging through SureScript. And you will know that if you notice my 7A on your letters out screen, you have an email type, and it will default to secured. And then you need to send it to another provider's secure email. And then the last mandatory base measure, also a performance measure, is receiving a summary of care. So this is now when you're getting a patient transitioned into your practice and you are receiving the CCD, which is the electronic continuity of care document. So the way this works is, again, you have to have that end-to-end secured email. It's going to come into your PrognoCIS inbox as an attachment. If your patient does not have an arrived encounter, as soon as you arrive them for their appointment, it's going to automatically attach this to the chart. That way you automatically get credit for it. So those are your 5 mandatory measures and how the data is captured in PrognoCIS. The number of patients is up to you. Again, the more the merrier. If you've chosen the minimal participation and you want to do ACI, you must do all 5 of those. Now we got our performance measures. Patient-specific education. This is when you are giving clinically relevant education to the patient electronically. Now for MIPS, in PrognoCIS for 2017, only the Medline education is counted. So for those of you who have been customers for years, prior to the Medline education, which is integrated through a web interface, we had internal prognosis education that you manually created. You can still use that within your practice, but it does not count for this measure. So under MIPS, you do need to make sure you're using the Medline education. That is available throughout PrognoCIS under your face sheet, under your assessment, under your lab results, wherever you have that little blue book in the column titled EDU for education. And when you click that icon, it opens up this link to the National Library of Medicine Education. And then at the bottom, you'll notice two choices, portal or email. So you can choose to send that to the patient by email or just activate it on their portal. And then once they log into the portal at home, they will be able to view that education link. Next option is view, download, transmit. This is again regarding the patient's health summary. We saw up above under the base measure, it's automatically available to the patient on the portal. One of the required measures is that you give them the access to that. Well, now this actually requires the patient to do something. So this is where it's kind of beyond your control, but you need to educate your patients that they need to go out there and look at their health information. They can also download it or transmit it to a third party. So when they log into the portal, on the left-hand side of the portal menu, they do have that choice called Health Summary. That is the one that's automatically generating in real time there. So if they just log in here and look at it, you're good to go. You'll get credit for it. They also have the option, if you notice the number 3 button, to print it, to download it, or transmit it electronically to a third party. There's also their past health summary. So if they don't want to do the current one, they can do their past ones. And this is now going to give you a list of every one of their previous visits. And again, if you notice the number 3 and number 4, they can view it, download it, or transmit it. Next performance measure is secure messaging. This is when at least one secure message has to be sent to at least one patient from your EMR to the patient under the patient portal. So this can come in a variety of ways. You can go under your PrognoCIS message compose, send an email message to your patient. Or if the patient has sent a message to you from the portal, you can reply to it. All messages on the portal are secure. Also, whenever you post lab or radiology results, since you have the portal activated, the patients automatically get notified of those results. So that counts. So this measure is very easy to be counted as compliant because if you're posting results and you have the patient portal turned on, they're automatically getting notified that the result is there. But keep in mind the note there under the second bullet point. Most clients, when they implement portal, set this property that the patient can only view the results after the MD or nurse practitioner has indicated they've reviewed the result. So you do need to make sure you're reviewing these results in order to generate the secure message. And then the third point is a patient form that the patient has submitted. Once you've accepted it into PrognoCIS, that is also a secure message. Patient-generated health data. Now, this is something brand new to 2017 that you did not have prior under MU. This is with regards to the patient submitting data to you, either verbally or electronically, and you're implementing it into your EHR. So basically, again, if they're submitting anything from the portal, whether it's a questionnaire, a history form, they're attaching something for you to look at, that is all deemed patient-generated data that you are now incorporating into your EHR. Clinical information reconciliation is for your transitions of care patients. You need to reconcile their meds, their allergies, and their past medical history. Pardon me. And then the last part is your public health reporting objectives. Now there's 5 of these total available. Compliance only requires at least 2 of them. So out of these 5, there's immunization registry, which is applicable to anybody who does vaccines. There's syndromic surveillance, which applies only to urgent care. Electronic case reporting is not applicable in 2017 for anyone, so you do not need to worry about that. Public health registry reporting is applicable to the National Ambulatory Medical Care Survey in 2017. And then clinical data registry is also not applicable for PrognoCIS users because you are using the other registry up above. Now for immunizations, for all of these, by the way, if they're not applicable under the settings master, you need to make sure you take the exclusion so that you're not penalized. But for immunizations, it does require a bidirectional interface. So this means not only do you transmit the vaccination data to your state registry when you administer it, which is an automated interface that you need to have turned on by PrognoCIS, but you also have the ability of importing from the registry into PrognoCIS a patient's vaccination history. So this has to, again, be enabled by Bismatics with your state registry if you do immunizations. For syndromic surveillance, if you're urgent care, then this interface needs to be turned on also to transmit the data to your public health agency that accepts it. Electronic case reporting is not applicable. Public health reporting, the only option for 2017 is National Ambulatory Medical Care Survey. There's a link there at the bottom of the page where you can go to register. It's a free registration. Only a sample of data is required as opposed to a defined number of days, and not even everybody will be asked to submit the data. So it's very easy to pass this measure. And this is also a bonus measure, you'll notice. And then clinical data registry is not applicable. So all of these, whether you do immunization, syndromic surveillance, or public health reporting, not only will they count as your performance measure, but you will also get bonus points for them. So that's your ACI category. Now the last category under MIPS is improvement activities. These are the ones, there's a total of 92. You need to report a number of points. So as long as you choose enough activities to equal 40 points, it doesn't matter if it's 2 high point measures or 4 low point measures. That's entirely up to you. It's not a number of activities, it's a number of points. And each activity is worth either 10 or 20 points. There's no data required in EHR. So basically this is very similar to that first ACI we talked about, security risk analysis, where you're going to be attesting yes. However, if you were to get audited, you need to make sure you have all of the appropriate documentation outside of PrognoCIS. Now that said, 18 of these are designated as ACI related, meaning they qualify for additional 10 bonus points. That would require EHR data capture. So you have a little bit of option here and flexibility. If you don't worry about any kind of data capture, just implement processes in your office and document your procedures, then you're good to attest yes come January. But if you also want those bonus points, then you choose from those specific 18 and then capture the data in PrognoCIS. Excuse me. So the setup in PrognoCIS is exactly what we saw in the other categories. You choose the checkboxes for the 40 points worth that you're going to go for. As you see next to my number 2 bubble, the ones that qualify for the bonus will have verbiage in that related ACI measure column. That verbiage is what indicates how you need to document it inside EHR in order to qualify for the bonus. These are the 18 improvement activities that also qualify for bonus. These 18 are included here in all 92. Now here at the end, I'm not going to go through these, but basically we are letting you know that different reports are available for each of those categories. Now come January, when it comes time to actually do your data submission, we will be having specific webinars on reporting. But for instance, right now, just so that you're aware, there is a claim-based quality measure report. So if you're not using PrognoCIS Practice Management, you can generate this report for your billing service. So that if you're using claim-based quality measures, then your billing service can make sure that the proper QDC codes are on your claim. If you're doing EHR-based, then you can generate the report to see how well you're doing at a measure level as well as at a patient level. You've got your ACI measures also to see your high-level performance. Keep in mind now at this point, you can create request a ticket out on your resource center for additional QPP training and assistance in setting these measures up if you're confused. But basically the point of this today was to help you understand how to read the measure definition so that you know how to capture the data in PrognoCIS and how we're going to be looking at it. So that's the extent of today's session. For those of you present, are there any questions? If so, you can raise your hand. There's a little icon there on your toolbar that looks like a hand that allows me to unmute you, or you can type your question to me. Excuse me. Okay, I'm not seeing any hands go up, so I'm going to assume all is well. You do see there at the bottom, we do have a email address that would go to our quality payment support team, but we are recommending and preferring that you log a ticket out on the resource center if you're needing further assistance. So I want to thank you for your participation, and I hope you will have a good week. Thank you.